Morning, everybody. Welcome to day 4. I hope you've enjoyed it so far. We've got a packed day of arrhythmia talks and a fantastic faculty with a real legend in EP joining us today. So it's a real pleasure to have this great sort of bunch of speakers today. So I'm going to start off with investigating arrhythmias. Which is a bit of a dry talk, but I think it's still important to cover some of the basics when we're dealing with patients with palpitations. So no disclosures. Okay, so I think it's very important to have a very logical approach when you're trying to diagnose patients who come to you with arrhythmic problems and palpitations. So it's very important to really hone in on the clinical history. Investigations will, of course, help in your sort of diagnostic approach, and obviously the crux is to capture the arrhythmia, and I'll talk about the methods that we use in order to capture common arrhythmias. So I think the first thing when a patient comes to you with palpitations is what does the patient mean? Because actually palpitations is a symptom and does not necessarily mean that there's an arrhythmia. So are they referring to their heart racing? And if so, is it, for example, too fast to count? Can they tap it out? Is it regular? Or actually, are they talking about a slower heart rate or an irregular pattern? Are they talking about pounding sensations, for example, ectopics? And sometimes I've had patients actually talk about chest discomfort when they're mentioning palpitations. So you really got to get to the crux of what the patient is talking about when they say palpitations. Clearly, associated symptoms are very important in trying to find out the sort of severity and the risk stratification. So are they syncopal, pre-syncopal? Do they have breathlessness? And is there an associated chest discomfort, which patients can have with or without ischemic backgrounds? Contributing factors, also very important. There are a number of patients who have anxiety and depression with concomitant palpitations, and it's worth exploring those aspects. Obviously, caffeine, alcohol, illicit drugs. And of course, don't forget prescription medications, so beta agonists, theophylline, thyroxine, all very relevant. And there's a small proportion of patients who may have very rare things provoked by QT prolonging drugs, of which the list is, of course, very endless, with things like antidepressants, antipsychotics, etc. It's worth also delving into the family history. So, does anyone in the family have any cardiac conditions? So you're looking for early onset atrial fibrillation, premature coronary disease, cardiomyopathies. So for example, if someone in their family has an ICD at a very young age, does this perhaps give a clue that there may be a channelopathy there? Sudden cardiac death, very important. Most inherited arrhythmic problems are autosomal dominant. So you're really looking for deaths before the age of 40, predominantly in first-degree relatives. And don't forget things like fatal accidents such as RTAs and drowning, because these may masquerade as sudden cardiac death in some situations. Epilepsy, often forgotten about, but actually a third of patients with epilepsy have an underlying arrhythmic problem and are misdiagnosed. So this is something to consider and shouldn't be forgotten. So investigations, of course, I mean, practically everyone that comes for an arrhythmic assessment has an echocardiogram, and you may pick up things like hypertrophic cardiomyopathy, RV dysfunction, maybe something rare like ARVC. Exercise tolerance testing is useful. I mean, you can have exercise-induced atrial arrhythmias, outflow tract arrhythmias, and is, of course, useful in risk stratification of HCM patients. And don't forget myocardial ischemia testing. So anyone who has significant coronary risk factors should have some testing in the context of palpitations. And don't forget those who are men over 40 and postmenopausal women in that assessment. But the crux is capturing the arrhythmia. And there's so many technologies out there now, and I think it's important to try and work out what is best in what situation. And the choice of technology should be based on the clinical context and, of course, the frequency of the arrhythmia and symptoms. And each technology has different time to diagnosis features and diagnostic yield, but both are equally important. And of course, remember, the more you look, the more you'll find, and not all of which will be clinically relevant. So in summary, This is just a brief sort of look at the frequency of symptoms and what you would do as a first line. So if it's daily symptoms, that's fairly easy. An ECG and a 24-hour Holter, which is widely available. If it's every couple of days, you can prolong that Holter to 48 to 72 hours as your first line of investigation. If it's a bit more sort of on a weekly basis, then think about 7-day Holters or event recorders. When it becomes much more infrequent, monthly, then you can have other options, but becomes more difficult. So you're looking at things like external loop recorders and event recorders again. And of course, if it's significant and far less frequent, then you should be thinking about implantable loop recorders. This was a nice algorithm published in the BMJ in 2017, but just highlights the things I've just mentioned, that if it's fairly frequent, you're looking at Holter monitoring, if it's weekly, external loops and events, and if it's life-threatening, hospitalization, and or you should be thinking about high clinical suspicions of arrhythmias, implantable loop recorders. So you're all aware of all the different types. This is an event recorder, the ARRYTH, and fairly recent years we've got more patch monitors which have different features, and I'll go through each of them in a minute. So conventional Holters, widely available, fairly non-expensive, non-invasive. The patient doesn't really need to do anything, and suitable for patients with frequent symptoms. And you're all familiar with the sort of readouts on the front page that you get from these conventional Holters. And it's just a picture of the patient wearing one. This is a graph showing some paroxysmal atrial fibrillation statistics on the heart rate histogram, and the sort of tracings that you'll see from Holter with an example of flutter, fibrillation, and sinus at the bottom. So event recorders, now these can be used for up to about 4 weeks at a time, usually available at more specialized cardiac centers, and of course are more expensive. They're non-invasive again, of course, they're very well tolerated, but the patient needs ideally to activate the recorder when symptoms happen. And that means that the patient needs to be able to adequately recognize their symptoms to activate. So that's one of the downsides. Because of the length, you're highly likely to detect arrhythmias, but again, not suitable for syncope when the patients may not be able to activate it. And remember, these all give single lead ECGs, so you can't really localize the focus of the arrhythmia, for example. And this is just an example of some of the readings you get from an ARRYTH. It's just showing some short pauses on one example. And a magnified strip of an example of a short run of non-sustained VT. So patch recorders, you'll have seen these, I think. They are quite expensive. Again, usually available through more tertiary centres. Non-invasive, you can see an example of one put on the chest here. They're very well tolerated. The patient does not need to activate. So for these things, 2 weeks of continuous beat-to-beat ECG recording. So different to the event recorders. The electrodes are closely spaced, so that is one kind of limitation. And again, you get a single lead ECG. And it's important to remember that different body types will give variations in quality of the ECG recordings that you obtain. But they're usually water resistant and fairly, if they're put on well, they are very good at recording good quality ECGs. And that's some of the output you'll see on the summary charts. An example of a paroxysmal atrial tachycardia from that patch recorder. And here just a further example of AF initiation and termination, just examples of what these things output. Loop recorders. So I'm sure you've seen that we've got lots more use of implantable loop recorders these days. This is the old generation of the Medtronic Reveal XT. The more newer generation is the Link. You can see how much it's shrunk in size. They're only 5 minutes to implant, fairly straightforward with a bit of local anesthesia, and there's of course the capability of remote monitoring. And these devices are implanted with this insertion device. And it's pretty well tolerated by patients. Recording time up to 3 years, actually probably more than that, up to about 4 years. clearly more expensive. There is a minimally invasive procedure, but is actually very useful in the right context. And important to note that there are both automatic methods of recording, which are preset from when it's implanted, as well as patient-activated methods. So that's one of the real benefits of using an implantable loop recorder. And this is just showing an example where you've got the heart rate histogram and an example of paroxysmal atrial fibrillation occurring from an ILR recording. And this is some of the tracings that you can find an example of atrial fibrillation. Remember that ILR works by detecting arrhythmia by detecting changes in RR interval. So there is room for error. And sometimes ILR recordings can be difficult to discern between, for example, atrial tachycardia, sinus tachycardia, and things like that. So it does need experienced physiologists to examine these. I put this in because I think this is relevant. In syncope, in the 2018 ESC guidelines, ILRs have been upgraded massively in their use. So if there's a risk of arrhythmia, whether it's high or low risk, ILRs are now upgraded to a class 1 recommendation. And interestingly, even if you've got things like unconfirmed epilepsy or unexplained falls, they have a class 2 indication. So they're used a lot more in this context. And interestingly, Holter's and tilt table testing have been downgraded in syncopal investigations. But you'll hear more from a colleague later on syncope. But why don't we implant ILRs in everyone then if they're so good? Well, they are being increasingly implanted, but there's clearly a cost impact. And of course, the other impact is the huge amounts of data that's generated by these devices, and the remote transmission burden is ever increasingly getting larger. So management of all this large data is very, very challenging. And what it does need is for the pacing clinic to be very proactive and to try and prevent unnecessary and inappropriate alerts. You need often to reprogram the device to the patient's needs as that journey continues over the 3 years of the device lifespan. And in some cases, external vendors are becoming an option for management of all this data. But again, big cost implication. But I wanted to come on to this because I think this is where things are really changing. So that was the bread and butter. But personalized ECG recording devices has really been a paradigm shift. Patients are now coming to us with a variety of different recording mechanisms, watches, smartphones, and we don't really know how to deal with this yet. But it is actually very helpful in the right circumstance. So you've all seen a LiveCore device, I'm sure, the Apple Watch, and there are very many other devices coming out on the market, some of which you'll never see because they'll never make it widespread, but there's so much, and I think it's worthwhile talking about how these things work. So, the way these things work are there's two main sort of techniques. The one you may have heard about most is PPG, photoplethysmography, which is commercially used a lot in pulse oximetry. The basic premise is that it uses the fact that blood absorbs more light than surrounding tissues, and the variations in blood volume affect the transmission and reflectance of that light. And the first sort of iterations of this were using your smartphone and the flashlight and a downloadable app. So this is an example of that. You can see your finger placed on the flash, and then a downloadable app, which then gives basically heart rate and regularity data. So you get a pulse waveform, gives you a heart rate number, and it can tell you whether things are regular or irregular. Nothing more than that. The second type of technique used in these devices is the electrode-based monitor. And it's usually in the form of a pair of external electrodes connected to a product, which is then Bluetooth to a phone, for example. And again, these are capable of recording a single lead ECG, so it's more information than just the PPG recordings, and can give decent single lead ECGs, which I'll show you in a moment. So this is the LiveCore device, which I'm sure most people would have encountered in their practice, whether you're EP doctors or not. And of course, the Apple Watch, which was the ECG particular aspect of it, was released with a lot of fanfare last year at the ACC. And this came because of the Apple Heart study, which is a study done by Stanford University in conjunction with Apple, published last year in the New England Journal of Medicine. And essentially, the key thing about it was the novel study design, actually. It was an amazing study because they remotely recruited about 400,000 patients in about 7 or 8 months. It was incredible. But it was a single-arm study with virtual monitoring, where they had the irregular pulse notification aspect of the Apple Watch with the phone on. And then if there were lots of notifications, then patients were sent a patch recorder to try and verify the results. There was a lot of fanfare, but actually, if you look at the hard numbers, the positive predictive value was only, 84%. And you'll know if you've read the study that actually it was more concentrated on lower risk, younger population. So not really reflective of the type of people we see in our clinical practice for atrial fibrillation, for example. And indeed, that's reflected by the PPV value. In those over 65, it is lower at 78%. So it's not perfect, but it's a great step forward in terms of giving patients more control over monitoring their rhythm problems. Taking things a step further now, ARRYTH have a kind of premium subscription aspect of their offering, and they've basically built in some artificial intelligence with some deep neural network testing in the background. And what they've done is essentially, with the Apple Watch, they are constantly monitoring your heart rate and activity levels from the accelerometer. And they're seeing if there's any discordance. And if there is, it will give you a little alert to record an ECG on the LiveCore single lead ECG device. So, for example, the best way to look at this is if the patient's not moving but the heart rate's jumping around, it'll say, oh, okay, this is a bit funny, record an ECG, please. Now, whether that comes up with AF or not, well, you don't know. It may be, for example, ectopics or sinus arrhythmia or something, but you can see how this is developing with the use of machine learning and AI. Many more devices on the market. You probably wouldn't have seen this. This is reasonably new. Wearable ECG, wirelessly connected by Bluetooth, single lead ECG again, continuous recording, loads of different parameters measured apart from heart rate, so skin temperature, respiratory rate, activity, of course. And then this I thought I'd put in for fun. I mean, there's an ECG T-shirt used in the sports domain. So T-shirt with electrodes printed onto the fabrics that feeds the ECG data to the cloud, which cleans the data, processes it, and then provides a single lead ECG. And I don't have an example of ECG, but I've seen them, and they're very good actually, surprisingly, from something embedded in the fabric. So this area is just exploding, and it's going to be something that we all have to contend with. The ARRYTH device last year had an upgrade, and I don't know if you've seen this, but basically you've got the 2 electrodes, but there's an additional one now they've come out with, which is on the back. So if you basically place the 2 fingers and then one on the bottom bit on your knee, you now get different vector configurations, which can give you a 6-lead ECG. I've got one of these given by ARRYTH, tested it out, very good. So it gives a bit more information. But to be fair, I don't know how much we try and localize arrhythmias from these sort of devices, but it can be helpful. So just to say that, even these small things are going beyond just a single lead ECG, which I think is quite incredible. Okay, so when you're dealing with arrhythmias, I think it's important not to forget the basics in terms of things like driving. So if a patient is troubled by them or incapacitated by arrhythmias, remember that driving should really cease. It's the clinician's responsibility to make the patient aware of this, but the patient's responsibility to discuss with the relevant driving authorities. So that's very important and is often forgotten, but it's something that we should all think about when we're assessing patients. And finally, Patient support groups. There are loads of patient support groups out there. In the UK and Europe, the Arrhythmia Alliance and the AF Association are fantastic portals for patients to look at if they need help, because there's so much information. And as you're aware, arrhythmia patients are often very, very worried about their symptoms, perhaps overtly so in some cases, but things like this can be very helpful in terms of engaging with others that may have the problem and just for information. I'm going to end with a case. This is a recent case of mine. A 26-year-old male, palpitations for 20 to 30 minutes, but sporadic, so every few months, and had and highly symptomatic, structurally normal heart, and had a few 7-day monitors done by colleagues. Nothing. But he was really troubled by these symptoms. Now, his girlfriend, I think, bought an Apple Watch, and then he had an episode, and he borrowed her watch, and this is the output. So this was very soon after I'd seen and said, you know, you should think about getting a personal ECG device, given that we've tried and failed to capture the arrhythmia. And you've got a beautiful ECG, clearly showing a really fast narrow complex tachycardia, suggestive of a typical SVT, and indeed he had an AVNRT, which was appropriately treated by catheter ablation. So it can be very, very helpful. These are very powerful devices, and in the right context can be so, so useful. So I'm going to end there with some take-home messages. The clinical history is clearly key. There are many options for ECG monitoring, and I've hopefully given you an overview of what's available and what can be utilised, including the paradigm shift in the ECG devices that are personal. The clinical context and frequency of arrhythmia and symptoms are super important when you're choosing the technology. And you know, there may come a time when all the usual things, such as Holters, may actually become far less important because of this rising availability of personalised ECG devices. I'm going to end there. Many thanks.